This is the second or third time I've been here, and the event seems to get bigger and bigger, which is fantastic. So, have I done a lot of work in preventing infection? Well, probably not. Hopefully what my team and I have done is to improve the way those with life-threatening infection are managed. We're going to talk about sepsis as the now not-so-hidden killer. We're steadily seeing a heightened public awareness around sepsis, and those who know me will know that I won't rest until it's a household word. I'm the sort of person that if I were told the organisation doesn't like the term toolkit, I would be motivated to use the term toolkit more. So we will see more and more public awareness on sepsis. Why? Well, it's because of people like Jem, short for Jeremy here on the left, who died 2 weeks after this photograph was taken on my intensive care unit. Jem developed sepsis within 48 hours of having had a vasectomy in the community. He'd returned to work, but he became progressively unwell, and he was describing odd symptoms to Karen. I've never felt this bad. I feel like I'm going to die. Karen described to health professionals in the community, I've never seen my husband like this. It's just not my Jem. He's not behaving like his usual self. As Mark said, we have to listen to patients, and we have to listen to patients earlier. And a large part of that is about dropping our professional arrogance. As it became clearer and clearer that Jem was dying, as my administration of vasopressors was going up, and his blood pressure was falling, and his blood acid levels were getting worse and worse, and I was needing to put more and more pumps by his bedside, I knew I had to tell Karen that the eventual outcome was likely to be poor. So I remember as clear as it were yesterday, following Karen down our hospital corridor, knowing I was about to take her into the relatives interview room and tell her that Jem was not coming home, and that she was going to have to go home and tell Tom and Emily that Daddy wasn't coming home, all from a condition that they'd never heard of. And I knew at that moment that had she asked me if Jem's infection precipitating his sepsis was preventable, I would have had to say, possibly not, we don't know. But if she'd asked a follow-up question, is Jem's death something that we could have avoided, I would have had to say yes, because there were many opportunities to rescue Jem that we didn't take, including in my hospital. This was 12 years ago. I hope we, and I hope the healthcare system as a whole, is a little better now. I'm going to have to change this slide, because this is Villa Park, the home of Aston Villa Football Club, and I'm going to have to change it because it no longer looks like that. It's no longer full very often. But I'm also going to have to change it because this is based on the estimate of the number of deaths from the 2013-14 hospital episode statistics data, which I'll share with you in a moment. But I now know what the absolute head count of deaths is from the indisputable sepsis codes within 2015-16 hospital episode statistics data, and it's a lot more than that. And we might need a stadium that's actually bigger than the Emirates Stadium, because that's the minimum end of the range before we start doing a further bespoke analysis. But at the time, we thought it was about 44,000, and we contextualised it. We said breast cancer claims about 9,500 lives every year in the UK, and it's right and proper we have to continue to drive improvements. Similarly with bowel cancer, 14,000 or so lives claimed every year in the UK. Sepsis claiming 44,000, and now a lot more than that, lives every year in the UK. That's more than breast cancer and bowel cancer and prostate cancer and road traffic accidents and HIV and AIDS put together. And of course, some of these will be double counted. Some of these patients will have died of sepsis following chemotherapy for breast cancer. Some of these people will have died of sepsis following bowel resection surgery for bowel cancer and have had an anastomotic leak, which, as Celia knows, is the anaesthetist's fault rather than the surgeon's fault. But notwithstanding that, these are countable deaths, and some of them, not all, are potentially avoidable deaths. And this goes hand in hand with two other messages. The rapid treatment of sepsis goes hand in hand with the prevention of avoidable infection, including through sanitation, hygiene, vaccination, but all the other strategies that you're hearing about today. But it also goes hand in hand with the antimicrobial stewardship message, because of course this is exactly the cohort of patients for whom we need to preserve those much needed antimicrobials. So those are the old data, and again, Celia will be pleased to know I've ghosted out the new data because we've yet to analyse them properly. But some of you may have seen some of the media coverage around this on Monday, where we announced that the headcount of the definite sepsis codes for 2015-16 was not the 150,000 or so episodes that we thought we saw, but actually 260,000 episodes. And put that in the context of sepsis being undercoded and underrecorded, and that's the minimum end of the spectrum. So we know what the mortality count was for those 260,000 cases, and I can't share it today, but just bear in mind the Emirates Stadium and its capacity. We also announced that this study estimated that the problem is costing the healthcare economy around 1 to 2 billion. That's direct cost to the NHS, but costing our economy as a whole £15.6 billion every year, with opportunities to save for the NHS alone £300 million by getting it right, and for the public economy as a whole up to £3 billion by getting the basic messaging and the basic management around sepsis correct. So these are the ghosted out figures, and I'm very pleased that I can't read them from here, because I'm pretty sure you won't be able to read them from there. But these were the 5 codes on the left that we counted. This is a more simplistic coding system than the government uses when they report on the number of sepsis cases. So this is ultra-conservative. These are definite episodes of sepsis, totaling just over 260,000. Now, we've talked about sepsis so far in terms of life and death. We've talked about a binary thing. But the reality, as this individual found, is that if you survive sepsis, you don't return to your normal function quickly. We heard in Parliament on Monday from Tom Ray, the young man who lost 4 limbs and had facial disfigurement as a result of sepsis, underwent many, many months and years of reconstructive surgery. And his wife very conservatively estimated to the Secretary of State that the cost to their family in financial terms was a minimum of £2 million. That's just one person. And we know that people who survive when we get it wrong, this is the global burden, that people who survive when we get it wrong don't always return to function in their normal way. This was looking at a longitudinal study of people who'd survived sepsis, mostly in North America. And they followed people up not for 1 year or 6 months, but for 7 years after surviving sepsis. And they found that 17% of people had moderate to severe cognitive dysfunction. Now, a clever doctor or a clever academic looking at this will say, well, I'm going to challenge the methodology. I'm not sure this is externally valid. I'm not sure that the surveys they used were validated. But step away from that, because this is about people. This is about what happens if you have moderate to severe cognitive dysfunction. I'll tell you what happens, because my charity picks the pieces up. What happens is you can't return to work. If you can return to work, you can't return to work at your previous level of function. Your finances are strained. When you couple this with the 22% incidence of post-traumatic stress disorder following an intensive care admission with sepsis, your relationship becomes strained. You can't sleep. You can't function. You can't be productive to society. You can't look after your children. The bottom line is, if we get this wrong as a healthcare system, it tears people's lives apart, and I see the thin end of the wedge. I'd like you to come on a leap of faith with me. The leap of faith is that where hospitals have implemented improvement programs, and in this one was 11 hospitals across North America, and they did 2 things. They put the sepsis 6 in the emergency department, and they said if the patient doesn't get better, you're going to call intensive care, and they're going to do all the sexy stuff with central venous catheters and vasoactive drugs and all that sort of thing. And they found that where the basics were delivered reliably, the patient was ineligible for the rest of the study because they frankly did not need the central venous catheters, etc. So we know from this study that doing the basics saves lives and avoids intensive care admission. The leap of faith I'd like you to come on with me is that if we can do that by avoiding intensive care admission, by limiting the acuity of illness, we will prevent the burden of survival, or at very least limit it. And that's got to be good not only for people, but also for our economy. So what is it? I'm going to fly through some slight challenges we've had recently around defining sepsis. We used to define it as a convenient continuum like this, but this is no longer the case. We used to know that the cohorts had mortalities that, when you got to the right-hand edge of the slide, were quite scary. Septic shock 50%. Well, I can share with you that in our evaluation of the most recent HEST data, septic shock mortality remains largely unchanged. But the sepsis mortality, which we used to call severe sepsis, is a bit better than it was. We had people telling us that for every hour we delayed in administering antimicrobials, the risk of death goes up by 7.6% in the most severe cases. So I understood, although I didn't agree, with the care pathways that started filtering through where they were treating people who just had a systemic inflammatory response to infection. This was potentially disastrous. We had organisations with PGDs for pip-taz or meropenem in people with uncomplicated sepsis, and we knew we had to change this. So we started as a bunch of people looking for the badness that differentiated those people who needed urgent treatment from those who didn't. And there were three groups. The first to come out was the UK Sepsis Trust. There's a reason for that. We don't bother with science. We resolve conflict and we agree what's pragmatic and sensible. So we looked at the international definitions, which were not workable. We looked at what we had available, which was the National Early Warning Score, and we took out the bits from the international definitions that we could measure at the bedside, and we called it red flag sepsis, and we agreed this with most of the Royal Colleges. And we said that this is a surrogate for an official definition of sepsis, and we would empower our juniors to treat patients with the sepsis 6 based upon those pretty abnormal physiological parameters. Mervyn Singer and his team with the International Consensus Definitions Task Force were looking for similar, and they evaluated a large cohort of patients retrospectively, 1 million or so episodes, mostly North American. And they found this thing called quick SOFA. They said if you've got 2 of hypotension, tachypnea, or an altered mental state, you're more likely to die. They didn't put lactate in there, although if you look at the supplementary electronic online figures, you'll note that lactate has a higher predictive value than 2 of the other parameters in quick SOFA. So they were proposing that we use this as a bedside score, but it's now been largely debunked. QSOFA crashes and burns. It fails validation. We've had now a prospective study of QSOFA against the National Early Warning Score and the Modified Early Warning Score, and in both cases, and unsurprisingly really, because those scores include the parameters within QSOFA and add a little bit more granularity with some other scores, they perform better at predicting poor outcome. So we're not currently recommending that QSOFA be used. We're recommending that health professionals start with either a clinical concern based upon risk factor evaluation or an early warning score that's triggering. And NICE had all this available to them when they were producing their guidelines. And what NICE did is to choose to tweak red flag sepsis slightly, and that's what they've done. So we still have red flag sepsis as an empowering tool to encourage health professionals to act. And I hope most of you will agree that with the possible exception of lactate and more than 2, all of those indicate that a person is quite sick. So we plugged it into some screening tools. They look a bit like this. Could this be sepsis? Patient's sick, someone's worried, the news is triggering, there might be some risk factors. Any one of those, proceed. Might it be an infection? Well, yes. You can't treat yet. You're going to look for a red flag. And we're only empowering people to treat with broad-spectrum antimicrobials if a red flag is present, according to NICE. Now, NICE recognised the need for a safety net, and they identified that it wasn't the case that you either had red flag sepsis, in which case blue lights and everyone get excited and start running around, or you didn't have a red flag, let's say your heart rate was only 128, and therefore you were fine. So they put in a redundancy, these amber flag criteria, about which there is some consternation, because there's less evidence base behind them, and they are a mixture of risk factors, objective measures, and physiological measurements. So some people, and I'm not proposing that this should be done, have simplified amber flags with, no, there's no red flag, but I'm actually still worried about this patient. Because it then goes down to clinical judgment. It's, do I need to send some bloods? Let's get someone senior and make an antimicrobial prescribing decision. So that's the current state of play regarding antibiotics in sepsis across England, Northern Ireland, and Wales. Scotland, SIGN have yet to produce their guidelines. We have new international guidelines for the management. So that was recognition, this is now management, nothing's changed. Okay? We used to have 2 bundles, the early bundle, which was essentially the sepsis 6, and the later bundle, which was called early goal-directed therapy, which is all the central venous catheters, vasopressors, and so on. The latter protocol has been largely debunked by 3 large international studies. So we no longer say thou shalt do early goal-directed therapy and target a mean blood pressure of 65 and a central venous oxygen saturation of 70%. We simply say the central tenets remain. Fill the patient up to correct hypovolemia, give vasopressors if their blood pressure is still low, and if they're not getting better, think about measuring their cardiac output and addressing that. So that's where we are with sepsis at the moment. the management is straightforward. It is the Sepsis 6, and that's why it's in 22 countries now and fairly standard across the British Isles. Is this enough? Well, we know it's not enough, because we know that this is largely a community-acquired problem. Some of these triggering infections might be preventable, many of them will not be. Pneumonia is the single most common cause of sepsis, and outside vaccinations, there is little we can do to prevent pneumonia in a number of people. So we know from the NCPOD study in 2015 that actually most people who had an ultimate discharge diagnosis of sepsis had sepsis when they arrived in hospital, and the vast majority were infected when they arrived in hospital. We also know that when they didn't get to hospital quickly enough, in the vast majority of cases, it's because they didn't ask for help early enough. So we have to work in partnership with our public. Where this meta-analysis found lasting improvements had been made, it's fairly clear that nowhere there did it say we've put some posters up and we gave doctors some cards to wear on their lanyards and we made some screensavers. We have to invest in improving sepsis outcomes. And we're obsessed with the airline industry, but for a time-critical condition like sepsis, I think we need to draw other analogies. Because for a time-critical condition, a checklist alone simply isn't enough. 1950 Indianapolis Grand Prix, the record-breaking pit stop at the time, 59 seconds. This car went on to win the race and was lauded and feted as a team. They had at that time a performance guy and a safety guy. So the safety guy was a race official, the performance guy belonged to the team, and their refueling pump had just got quicker. So the performance guy, history tells us, noticed that the refueling guy had finished. The first guy on the wheels was still finishing the first wheel before moving around to change the second wheel. And he noticed that the refueling guy was doing unnecessary things like adjusting the driver's seat belts and wiping his thing and even giving him a glass of water in a minute. We assume it's water. So history tells us again that the very next season there was nothing to prevent them having two people changing wheels, but it was not needed until now. So the next season they brought a second person in to change wheels and shaved another 15 seconds or so off the pit stop time. And again the car went on to win the next season's championship and everything was lovely. But even in those days they had team training, crisis simulation, task focus. The wheel guy didn't go and do some refueling and vice versa. Fast forward 60 years to Melbourne in 2013, and we now have a huge team of people. We have performance guys, safety guys, people training together as a team, task-focused people, simulation-based training, including crisis, 3 people on each wheel, one of whom is actually a redundancy. He's not needed. He's not doing anything. I assume they're mostly he's. I'm not being sexist. We had the jack people at the front and back. They didn't occasionally change wheels and vice versa. We now have the car out of the pit, not in 59, but in 2.9 seconds. So I'm not saying we need to give antibiotics in 2.9 seconds to people with sepsis, because we don't know whether we need to give them that quickly. What I am saying is that we need to start to draw analogies, and if we're going to improve this, then just like trauma care, we need dedicated personnel to do it. We need investment. The other thing I'd say is I'm pretty sure that Ferrari didn't circle the track for 3 laps thinking, my fuel tank's a bit empty, my tyres feel a bit worn. Shall I bother them in the pits? No, they'll only think I'm causing a fuss, and anyway, they'll make me wait for 4 hours before anyone does anything. So we have to get back to this partnership with our public. We have to embrace the support that the Secretary of State and Sir Bruce Keogh and Celia and her team are giving this, and we have to continue to drive for improved investment and improved clinical systems for change. We have to invest in people, we have to invest in data. Some of you will have heard the story of little William Mead, whose mum contacted the NHS not 1 time, but 20-odd times before he sadly died alone in his cot at home, possibly unnecessarily. I think the opportunities to rescue William were largely in the last 24 hours of his life rather than in the 3 or 4 weeks he was deteriorating. We will continue to use critical partners like the Daily Mail, which is much maligned in the healthcare professions, but is very good at heightening awareness and driving change. And we will, of course, continue to use other vehicles for us. This was the biggest coup I think I've had in my career. Getting our posters onto Holby City was fantastic. I'm very, very proud of that moment. So there's Dr. Jasmine Burrows and Dr. Wolf, and there's Serena, all over this patient with the poster in the background, raising awareness, viewing figures of 5 million people. It's very good free advertising. We have printed with Public Health England 1.1 million leaflets and posters, and these are being distributed to pharmacies, community care centres, general practices, hospital waiting areas, schools, and so on and so on. We're starting to see, anecdotally, members of the public taking snapshots of these in very odd places and sharing them with us. So we're empowering the public to think sepsis if they're deteriorating in the context of an infection, ask could it be sepsis, and to know where to look for the symptoms that might help them to be a little bit more assertive in demanding a response from the healthcare system, of which I am still a full-time part. We're working with pharmacies to try and get them to share some messaging and safety netting. We're working with out-of-hours doctors groups and GP collaboratives, and we're working with the ambulance services to get them to share the messaging. We're also going to be working with corporate partners to get them to share. So, in essence, the public are going to be empowered to ask, could this be sepsis? We're going to give them safety netting resources. This is for adults. The cards are available quite widely. It's based upon a modified Delphi approach among 200 survivors, so some science behind it. These are the paediatric pieces of information. And those of you who are able to read quickly, because I'm going quickly, will know that the symptoms on the left, really most parents worth their salt would act quickly if their child had any of those symptoms. So there's no real change here. We're just getting the word sepsis into their vocabulary. We're adding more detail to that based upon the Nice Feverish Children guideline and working with the Royal College of Paediatrics and Child Health together with Public England to empower parents in a wider list of symptoms to act. And we're being quite didactic. We're saying if your child has any one of these quite bad symptoms in the context of infection, go to A&E or call 999. And again, parents are going to increasingly be aware of this because we're seeing more and more CCGs including these resources within the child personal health record. So that's all I want to say. I'm just going to finish by promoting our non-pecuniary relationship with this film Starfish, which is a beautiful, beautiful film. It's about the aforementioned Tom Ray. He doesn't play himself. He's played by a BAFTA award-winning actor, and his wife Nick is played by a Golden Globe-winning actress, Joanne Froggatt from Downton Abbey. It is beautiful. It's not a story about sepsis. It's a story about love and family and hope and determination. But it does raise awareness of sepsis. And the reason I'm telling you all this is we have exclusive non-pecuniary distribution rights that if you wanted to show this in your hospitals, there is a small payment to the producers, but it can be arranged and we can facilitate that for you. And if anyone would like to do that, the contact is pippa, P-I-P-P-A, @sepsistrust.org. Together we can save 14,000 lives. Well, in the summer we're going to be releasing these new mortality data, and we might be suggesting it's rather more than 14,000 lives, but I think 14,000 lives is a pretty ambitious starting point. Thank you very much.